So the pathology is multifactorial, as we already mentioned. But what's really interesting is the amount of nervous system tissue that we see from surgical procedures or from autopsy that shows neuropathy in patients who are completely clinically asymptomatic. So it does seem to affect tissue, and in some patients, clinical symptoms just don't show up. People are just resistant, which is interesting and not well explained. Okay, now we can't advance. So that I don't know. Thank you. Back in the bad old days, everybody is familiar with these three: D4T, DDC, DDI. Very, very neurotoxic agents. Almost 80% of anyone who's been exposed to these agents will have some amount of neuropathy, even if it's not clinically expressed. So those were the olden days. And it's different than the chronic neuropathy we see. The antiretroviral induced neuropathy comes on usually pretty quick after exposure to the product. It often will affect arms more so than legs. And it goes away sometimes pretty quickly if we get it off fast enough. So it looks a little different than the generic neuropathy that we see most of the time. And, as we are aging, there are other comorbidities that make this neuropathy issue worse. And that can be vitamin deficiencies, type 2 diabetes, all of this stuff that happens to everybody as they get older. All of those things we're not immune to that. So as the patients come in and they're older today, we have to do a better job of screening for alternative issues or comorbidities that are making HIV neuropathy in and of itself worse. And there is an acute HIV neuropathy that is not like the chronic one, but this is usually associated with seroconversion. Because the virus is neurotropic and because it has an affinity for nervous system tissue, people who are recently infected will certainly develop this acute neuropathy. And, it's interesting. It looks a little bit different because it can involve the cranial nerves, so you can get Bell's palsy. That's always an issue. Anybody who walks into the emergency room or urgent care with a Bell's palsy needs HIV screening. And it can also present like Guillain-Barré syndrome. So people can be very weak very quickly and very sick. So that's just been around from the beginning. Luckily, we don't see it as much as we used to. And then there are some very rare things that happen. There's mononeuritis multiplex, which means multiple nerves get infected at the same time. So you may have a carpal tunnel of median neuropathy on this arm, but on the other foot, you may have a foot drop from a peroneal nerve palsy. So we do sometimes see mononeuritis multiplex. Vasculitis, or inflammation of the arterial and venous system around the nervous system, can also occasionally occur. That's generally drug-induced or autoimmune. And we talked about CIDP. Other thing that happens is zoster, shingles. Shingles really affects the root of the nerve as it tries to get out of the spinal cord and into the limb. Hits right at that root, and so you'll get that dermatomal rash and very severe pain. And lastly, and very rarely, autonomic nervous system, the system that controls blood pressure, heart rate, sweating, bowel and bladder function, very rarely, but occasionally affected by HIV. And so those are a small subset of patients, but they are there. And we always have to keep that in mind if people are having problem with blood pressure management, bowel bladder dysfunction. We always have to think, could it be a nervous system issue as well? There is a very interesting phenomenon known as the HIV hyperimmune response too, which causes neuropathy very quickly because there's a very diffuse infiltration of the tissue very quickly, particularly with the beginning of antiviral therapy because of dysregulation of the C8s. So when we start people on antivirals, we keep our eyes open for these kinds of things. There's also problems with CMV, which we see less of now that we've got better control of viral load and better T cells in general. But CMV tends to like the nerves at the base of the system, what we call the cauda equina, or it's really means the end of the horsetail, where all the nerves sit at the base of the spinal cord. So people with an HIV-related CMV comorbidity can sometimes have that problem where there's bowel and bladder involvement, there's lumbar pain, there's lower extremity weakness, and generally, we check it by looking for the CMV directly in spinal fluid that bathes those nerves. So we've got lots of complicated stuff there. And something very rare but interesting is the HIV-related motor neuron disease. And this is basically ALS, or I guess people would still say Lou Gehrig's disease, although we're moving away from that nomenclature. And this is just like regular ALS. People present with fasciculations, muscle weakness, and interestingly, it responds to antiretrovirals if it's HIV related. So another interesting thing that we nerdy people look for. And we can talk treatment, and we can say the following. Even here in 2025, there are still no FDA-approved medications for the treatment of neuropathic pain and HIV. All neuropathic pain agents are studied in diabetics. And the reason for that is because it is the most common cause of neuropathy in the United States. So if you need to study a drug and you need to get 2,000 volunteers quickly, the way you do it is you enroll people with diabetes. And most studies of these kinds of agents excluded people with immunocompromised states or malignancies. So we don't really have data for all of us. So we know that we need to remove any drug that's causing trouble. We know that we have to look for the comorbidities like diabetes and take care of that. And we know that we try to extrapolate the data from diabetics to people with HIV to figure out what we can do to provide some relief. And tricyclic antidepressants have been used from the very beginning, even when I first started in 1985. And to this day, we still use amitriptyline and nortriptyline at various doses. But tricyclics are more of a problem in our population because as we age, they're very anticholinergic, so they can cause slow heart rate, bradycardia. They can cause urinary retention, which is already an issue, as we all know, and all those other things that we don't want, including fainting spells. So I tend to not do this in this demographic, but I think the serotonin selective reuptake inhibitors, particularly those like duloxetine that also inhibit norepinephrine reuptake, the data comes from diabetic neuropathy. The data is really strong for that. Duloxetine is, of course, an antidepressant medicine marketed as Cymbalta. But what happened is during the study of depression, the depression indexes didn't budge all that much, but the people said, you know, I used to have very painful feet and I don't. So there a marketing opportunity was born. And so the manufacturers of duloxetine decided to look at diabetics, again, diabetics, and they found it did help. So that is still an option for us. And my friends at UCSF in the pain management department love topical anesthetic gels. And I mix them in all combinations. I can do nortriptyline, gabapentin, ketoprofen, fentanyl. You can mix it all up. I don't think any of them is particularly known to do any better than any other one. The problem with topical gels, I don't think they're user-friendly. You've got to put this stuff on your feet every night. It could take weeks to kick in. You got to wear gloves so you don't anesthetize your hands while you're in the process. You know, here we go, because none of this is FDA approved, none of this is insurance covered. So, you know, it's cash and you have to go to compounding pharmacies, kind of a hassle, but it can help. Everybody gets gabapentinoids. Gabapentinoids are the mainstay of neuropathic pain control in the United States. And if you look at data, the data suggests that gabapentin is more effective at higher doses than at lower doses. The sweet spot seems to be about 1,800 milligrams per day in divided doses. So what that means is people under 1,800, if they're not getting relief, we can push up to 1,800. Once we cross past the 1,800 sweet spot, we tend to see more side effect and not so much benefit anymore. The curve seems to just sort of asymptote at around 1,800. So we've got that. And there are people, individuals, who are very fast metabolizers of gabapentin. And so I anecdotally can tell you, I have seen people taking as much as 8,000 milligrams a day, which is, I know, it's hard to believe that they're awake and alert, but they're in my office chit-chatting with me. So, and I believe them. Okay, so be careful. Kidneys don't like gabapentin. When kidneys get slow, when you're sick, the gabapentin is not eliminated well. It gets up into toxic levels, and we start to get the usual gabapentin side effects: cognitive clouding, imbalance, ankle edema, diarrhea, GI upset, and involuntary movement. I see a lot of movement. If something twitches, it winds up in my office. And very often, the first thing I look at is the medication list, and then I look at kidney function. And very often, patients are on high doses of things like gabapentinoids, but the kidneys have slowed down and they're no longer able to metabolize it. So we got to change dose. A lot of people ask, what's the difference? Why can't I get pregabalin, which is marketed as Lyrica? For number one, it's the same drug. It gets a little higher serum levels because it doesn't need to be cleaved by the liver to get to the serum. So some people feel it works a little faster, which lets you dose lower, 200 to 600 milligrams per day, but it's controlled. So it's a hassle for providers. It's a hassle for pharmacies. And, it also has the same problems with the kidneys. So you can't get around it. It has a lot of weight gain for a side effect, so sometimes that's an issue. But both of them work by irritating the GABA, which is GABA hydroxybutyric acid, which is a neurotransmitter in the brain. We don't fully understand the mechanism of action of these drugs. The gabapentinoids were not developed for pain. They were developed to control epilepsy. They were developed as anti-epileptic drugs. So, again, the data for pain management is anecdotal, and therefore there is no clear pathway to figure out for who does this work better at which dose or which product. So there's a lot of trial and error involved in it. I won't deny that. So one thing that I like alpha lipoic acid, 600 to 1,200 milligrams per day. It's a nice over-the-counter supplement that I think does help protect neural health. I think the nervous system tissue likes it. I think that's a reasonable thing. And occasionally, for people who have failed everything, lamictal or lamotrigine is another anti-epileptic drug that seems to help. So the question everybody asks is, what's with the seizure drugs? What's with the anti-epileptic drugs? Well, look, people have seizures because their brain misfires. People have neuropathy because the peripheral nervous system misfires. So it's logical that if it would work to stop central nervous system seizure, it might work to stop what we call emphatic transmission in the peripheral nervous system. Emphatic transmission means that the nerves are getting signals that are like the torn up telephone wire we talked about in the beginning. So that's why all these seizure medicines come across. It's just the nature of the nervous system tissue. There's a lot of alternatives out there. I've got a lot of trials. I've got conflicting data, so I can't tell you whether they work. Acupuncture, cryotherapies, some people swear by them. I tell everybody the same thing. If something helps you, you should use it. But if you're asking me, is there data? I can't give you that data. We just don't have data. So I tend to say, be very careful that you're not spending into bankruptcy on some of these things, because a lot of times in alternative therapies, if it doesn't work, the response that you get is you need to do more. So you have to just be a little careful there. I was involved in trials for peptide T, prosaptide. We just didn't see anything. Modern times, people are interested in stem cells. Stem cells work beautifully for my multiple sclerosis patients. They're probably as effective as some of the disease-modifying drugs, but they have not worked for Parkinson's. They have really not been shown definitively to do anything for nervous system tissue. So again, I'd be very careful about expenditure on that. And we have done studies of nerve growth factor, trying to inject the nerves with the human factor that makes them grow to see if we can regenerate them. What we got was a lot of scar tissue and not functional nervous system tissue. And that's very similar to what we had with Parkinson's disease. We inject stem cells into the movement disorder center of the brain. What do we get? We get a lot of growth of new nervous system tissue, but it's all misconnected to the wrong wires. So the clinical response is not there. And there are always general recommendations. I strongly recommend exercise. There's no portion of the body that does not benefit from good circulation. Again, trying to get reparative proteins into your nervous system tissue is not going to happen if you're not fit. You've got to have a good, healthy cardiovascular system. Foot care and foot inspection are very, very important. We don't talk about that enough, but in the office, I always do with each and every one of the persons in front of me. You got to look at those feet every day, because little cuts in neuropathic feet, you don't feel that cut, it becomes infected, and we see way too much gangrene and we lose way too many toes. So every day, just like diabetic feet, they need to be inspected and they need to be taken care of. They should never be walking around barefoot. These are not good feet for bare feet. So that's another thing we need to do. And we talked about imbalance earlier, fall risk reduction. I go over this all the time. If a cane makes you steadier, then that's your best friend. There's no shame in an assisted device if it means you're not going to fall and break a hip. So I like them. I will tell you, lastly, for the first time in 25 years, this last week, the FDA has approved a new medication for pain. And it is a novel agent because it is not a gabapentinoid. It is not an antiepileptic. It is not a tricyclic. It's a sodium channel blocker. And I don't know what focus group came up with this name, but I'm not even sure how you pronounce it, but it's Journayx, Journavx. It's technically a suzatrigine. It's one pill twice a day, 50 milligrams. It was studied in acute pain as an option for people who don't want to be on opioids. And it was very successful and therefore passed trial and got FDA approval. Should be in the markets in the next 2 weeks. It should be on the pharmacy shelves. So here's the deal. FDA has only approved it for acute pain. So it's like for post-op pain. So you can get it for a 2-week supply. Therefore, it's not FDA approved for chronic pain, which means insurance is not going to pay for it for neuropathy. More important news, some people in my world, in the nerd world, have some inkling that this may be helpful for some peripheral neuropathy based on results that they've seen in diabetics. So stay tuned. There may be new things coming very soon. And to get back to my disclosures, this is why I don't take pharmaceutical money. Anyone want to guess the price of one of these pills? Yeah, $15 a pill. So you need 2 a day. So that's $30 a day. Yeah, so if you're on it chronically, do the math. Not good. Yeah, insane, right? So that's my material for today. I apologize if I was discombobulated. It's been a long work day, but now I get to learn from you because I will take any questions, comments. Can I turn this off so I can see better? Yeah. A blank screen somehow. Thank you.
What's the story with gabapentin time release?
Oh, the question is what, I'll
Yeah,
go from here.
It really does make a difference.
Yeah, it really does. What's the story? The question is, what's the story with the gabapentin time release? Time release gabapentin is, in my opinion, very similar to regular gabapentin, except it costs more. When pharmaceutical companies lose patents, the way they extend patent is by changing formulation. And then they will give you all sorts of information that this is much far superior. So for restless leg syndrome, we have a product called Horizon. It is gabapentin, 600 milligrams, and you take 2 pills at bedtime, and it's supposed to be extended release. And it's supposed to be much better than regular gabapentin, but every one of us switches it out to regular, and the patients get the same response. So I would probably suggest people save money, but if it works and you got it, use it.
I have another question about mirtazapine. I
Okay.
used to take it years ago for weight gain, and I guess it was an antidepressant. I tried it a couple of years ago, and it gave me restless leg, like really bad. So I stopped it.
Mirtazapine. So
Yeah.
the question is mirtazapine, which is marketed as Remeron. Any of those psychoactive agents that are used for sleep or depression, as mirtazapine frequently is, mostly for sleep nowadays, you can always trigger a paradoxical response in the nervous system. So restless leg is often precipitated and exacerbated by other psychoactives. So very often less is more when it comes to these products, and I spend a lot of time editing people's medication lists because everybody means well, and every time they go to a doctor, they mean well and they get another prescription for another agent, but sometimes nobody takes agents away. And I think that's problematic. Central nervous system polypharmacy is a major issue for me.
Any interventions or diagnostics for bowel bladder involvement of the nervous system?
Yes, bowel bladder involvement in the nervous system is the question. How do we do that diagnostic testing? The bowel is difficult, but the bladder is a little easier because we have urodynamic testing that can be done by a skilled urologist. And the results of urodynamic testing can sometimes point the finger towards the nervous system as the loop rather than the bladder or the urethra or the kidney.
Any comment about magnesium, spray, pills, etc.?
The question is magnesium for neuropathy. I haven't seen data for magnesium specifically, but again, if that's a supplement that someone's trying and it's helpful, it's great. Magnesium as a supplement orally or intravenously is limited by gastrointestinal issues, particularly diarrhea. So I am very loath to ever suggest magnesium for anything because it will be followed by a phone call the next day about diarrhea. So, yeah.
Milk and magnesium for a reason.
Yeah.
Thank you so much. When I was in the first 10 years of my diagnosis of being HIV positive, I contracted shingles all of a sudden. And then about 4 or 5 years after that, I was taking lunch at work and my face got paralyzed with Bell's palsy. And I always thought there was more to the story, and thank you so much for the revelation of some other things that might have been going on with my physical body. And I ended up with a facial therapist who helped Buttafuoco's wife when she got shot in the head. And it was very helpful, but still, like 20 years later, people say that I smile crooked or my eyebrow is off. And I hadn't ever related it to HIV, but I always felt like there was more to the story. So thank you so much.
Well, you're welcome. You're very welcome.
Could you talk a little bit about silent neuropathy? I was diagnosed with that. I'd never heard about it before.
Oh, yeah, silent neuropathy is the question. And that is basically, as we talked about a little bit, that you're one of those folks that there's stuff on exam that looks like neuropathy, but it's not a major factor in your daily life. So I will tell you that if I do a detailed enough exam on almost any chronic HIV infected person, I will find neuropathy findings. I will see loss of distal tone, I will see loss of distal reflexes, I will see loss of distal sensation, even though they're there for migraine. So silent or subclinical, that's really where you're at. So a well-known phenomena, a very, very significant percentage of folks.
I'm glad you mentioned something about this. I've been suffering with balance issues for 14 to 15 months. I've gone to physical therapy, nothing's worked. I've had brain scans, MRIs with a lot of contrast, specifically looking at the inner ear, nothing's worked. I've been to 4 different physicians from Eisenhower, so you need to tell them that perhaps peripheral neuropathy and balance are involved, because that never has come up. And
Yeah,
I'm gonna bring that up with them when I talk to my neurologist the next time.
well, it's a very important distinction. I appreciate that. Unfortunately, a lot of times that there are balance issues, many providers go directly to brain or other concerns. I think sometimes, though, it is just a peripheral sensation issue. If you just don't get those messages coming up from the feet on the floor, balance cannot be good. Be careful.
You mentioned diagnosis of feet feeling hot
Mhm.
when you're walking on a cool surface.
Right.
What about feet feeling wet when you're walking on a dry surface?
The question is, feet on a cold surface feeling hot, feet on a dry surface feeling wet. Yeah, that's exactly the problem with nervous system tissue that is not healthy. Transmission is inaccurate. So people tell me with neuropathy, they feel like they have 3 pairs of socks on their feet. They feel like there's something bunching up in their shoe all the time. They'll tell me the floor feels grainy and pebbly when it's a smooth surface. So dry versus wet, I can understand people would have that misperception because the system is not well.
So 15 years HIV positive, no viral load, treatment naive, have had no opportunistic infections. Neuropathy, is it caused by HIV inflammation?
Yeah, there's definitely there's 3 ways to get that. There's 3 ways to get that neuropathy. You can go directly from viral irritation of the nerves themselves. In your case, not antivirals. And of course, from inflammation in the system from fighting a chronic virus. The human body does not like the pro-inflammatory state. And we get into pro-inflammatory states when we have chronic illnesses, autoimmune diseases, also when we have poor nutrition, and we live under stressful conditions. So addressing general health goes a long way to making sure you stay as well as you've done. So keep up the good work.
You mentioned bare feet and HIV.
Yeah.
Neuropathy of the feet are not a good combination. However, going with socks on in the house seems to be, helpful for keeping them warm. But if I put shoes on, I'm relying on all that cushioning, and I don't know that I'm really helping my balance. Is there a recommended path here?
Well, so the issue is, what do you do about bare feet? Socks, shoes. Will it impair balance, become more sort of dependent on shoe? I think it's very individual, and I think that it depends on what your activity level is, what your general physical well-being level is, what your strength is. But I can't tell you how much time I spend on a weekly basis with feet that get butchered because something will fall off the counter and it will always fall on the neuropathy foot, right? Some shard of something will somehow find that foot. The rest of the party, nobody got cut, right? And so quickly, especially in our patients who are aging, the circulation to those feet is not great. The neuropathy has taken away a lot of sensation, reflexes down. We quickly get into bad spaces. So I know it's convenient to be barefoot and it feels nice in some cases, but I would limit it to very restricted situations because it always happens in the kitchen. Always.
First of all, thank you so much for everything that you said tonight. I've been HIV positive for over 40 years, and many of the things that you pointed out are collecting some dots that I had never really thought of before. However, in regards to neuropathy, I've been on gabapentin for probably a couple of years, if not a little more. And I do experience the brain fog and cloudiness. It comes and goes. Now that I walk every day for over 30 minutes, it's much better. The other concern that I have is the kidney thing. What are some things to do, like increase more fluids a day or anything, any points on that?
Okay, so the issue is the worry about gabapentin toxicity with kidney insufficiency. Know this, gabapentin in and of itself does not harm kidneys, but kidneys are harmed by dehydration, they're harmed by other medications, they're harmed by aging, they're harmed by untreated hypertension, they're harmed by diabetes. So good kidney care, yes, hydration, of course, but also attention to all those other medical factors. And if the kidneys are getting slower, then your provider needs to adjust gabapentin dose downwards. You need de-escalation of dose so you don't get sick. So not the gabapentin causing the kidney trouble, but bad kidneys and gabapentin don't get along well.
I have a question about nerve growth factor and also about whether L-carnitine is recommended with alpha-lipoic acid. I was told that the two were necessary years ago.
Yeah, the nerve growth factor trial was a stunning failure. Just we didn't see anything great on pathology reversal. We didn't see anything great on clinical response. And it was cumbersome. The second issue about alpha-lipoic acid, L-carnitine, I'm just cautious about the L-carnitine because I'm careful about kidneys. So the alpha-lipoic acid, I don't see an issue or fear, but I have an aging population, and so I do see some kidney struggles and want to avoid supplements that can sometimes make that worse.
Any questions?
This is a good group. You pay attention. I like it.
Gold star.
Again, thank you so much. I just want to know, are there other places besides your gloves and stockings where neuropathy takes place?
Well, there's a wide variety of neuropathies, and mostly with HIV, we're looking at stocking glove for the majority of our players. But yes, you can get neuropathy in all sorts of places because your whole body is innervated by nervous system. So there are nerves everywhere. Interestingly, the nerves go away inside brain. Only the covering of the brain, the meninges and the dura and the skull are where we have nervous system tissue. Once we get past that in surgery, we can turn the anesthetic off and we can dig in the brain as much as we want, which is why Patients can be awake, and we can ask them to raise their right hand, raise their left hand to make sure we're not in a bad spot of brain tissue. So the only place that you can't get the neuropathy, as best I know, is if you go deep inside brain.
Useful information.
Well, I told you, this is a nerd-based talk. It's a nerd-based talk full of fun facts.
So there seems to be, when people go to a specialist, sometimes they'll go to vascular people because it'll seem like there's a vascular issue, like a circulation issue, when it could be neuropathy, it could be combinations of both. So what kind of suggestions would you have for providers when they're doing one route or another, when it could actually be maybe the other one or maybe both?
So the question is, can the problems in the feet be nerve-driven or vessel-driven? And you're correct, it can be both, but vascular disease causes cyanosis or discoloration. It causes loss of peripheral pulses. It causes cold feet. And the nervous system tissue causes numbness, tingling, burning. So I sometimes tell providers that a clearer history can sometimes help determine which direction the patient gets sent. But you're absolutely correct and quite astute in your observation. Very often people come to me and they've spent a lot of time at the Vein Institute, and actually it was just neuropathy. But I don't dispute that people can have both. We are all multifactorial human beings or multi-organ humans. We have many things that overlap. But I think the answer is really a better history and a better exam. Does that help? Yeah.
Any difference between men and women?
Gender differences in terms of neuropathy or response to treatment. Well, I don't know that there is any data about gender difference, and partly because, getting back to it, we don't have any data for these studies that is outside of diabetic. So I don't think there's any way that's been broken down by male and female. I don't think so.
And the other issue in HIV, there have been some really small studies. If you're familiar with the HIV Neurobehavioral Research Center, they've done some small studies over the years. But the problem in all HIV research is that never enough women are recruited in trials.
Yeah,
There's a difference in that.
Years ago when I worked for the AIDS Research Alliance, where we did clinical trials, we couldn't even get the bare minimum requirement of women into studies for even HIV vaccines. It's a tough spot. So all the neuropathy stuff is diabetic based, and I don't think those studies spend a lot of energy between male and female.
Anyone else? If not, thank you, Dr.
You're welcome. Thanks.
And we'll see you next month. Next month's program is going to be the anal cancer prevention. So it'll be John Colbert and Anthony Velasquez talking about cancer prevention. And there'll be demos.